So, good morning, everyone. Oh, in okay. So I'm just gonna double check. Yeah, everything's fine. Good morning, everyone. My name is Apu Karajagi, and I'm the Injury Prevention Officer at Injury Matters. And I'm so excited to be facilitating this webinar today. Our webinar is called Poisoning Prevention in WA. So before we start, I just wanted to acknowledge the traditional custodians of the land on which I am facilitating this webinar today, which is the Whadjuk Noongar people, and I want to pay my respects to their elders past, present, as well as their leaders emerging. Australia always was and always will be Aboriginal land. And I'd love to know where everyone else is tuning in from today as well. So acknowledge the country you're on in the chat box. So feel free to use the chat box to acknowledge the country you're from. And so before we start, I just wanted to go over a few housekeeping points. So I know everyone's already muted and their video is turned off, but just double check that it is so that we can hear the presenter clearly throughout the webinar as well. Also, if you have any questions, feel free to pop them in either the chat box or the Q&A tab as well. We have a Q&A box that you can put your questions in. We'll take questions at the end of the presentation. And also, if there's more than one person with you tuning into today's webinar, just let us know by putting how many people are with you in the chat box. That will just help us know how many people are actually tuning into the webinar today. And also, if you have any tech issues throughout the webinar, just let us know, and we have Joe helping with any tech issues. So we'll get to you as soon as we can. And also, the webinar is recorded, and everyone will be getting the webinar recording in a follow-up email as well. So I just wanted to talk about Injury Matters and who we actually are. So Injury Matters is for safer people in places. We aim to prevent and reduce the impact of injury within the WA community. And we do this through advocating and providing education for injury prevention, as well as providing support for people who have been impacted by injury. And today's webinar is through the No Injury program, which is supported by the WA Department of Health. No Injury is a statewide program which aims to enhance the capacity of the injury prevention and safety promotion practitioners to deliver quality injury prevention activities. And we do this through training events such as the webinar today, as well as resources and networking opportunities to support the sector as a whole. So today, our topic is poisoning and injury. And unintentional poisoning is one of the leading causes of injuries in WA, accounting for 179 deaths in 2021. And in WA, between 2015 and 2019, there were 11,308 hospitalizations due to accidental poisoning, and 57% of hospitalizations for accidental poisoning were males. And people aged 25 to 44 had the highest incidence of accidental poisoning. So, to talk more about these statistics, what they mean, and how to prevent poisonings in WA, I'd like to introduce you to our speaker for today, Louise Edwards. Louise is a registered pharmacist and specialist in poisons information with over 8 years of experience at the WA Poisons Information Centre. So, I'm going to hand it over to you, Louise.
Good morning, thank you. I will just share my screen, bear with me. All right, give me 2 seconds. Thank you for having me, and thank you for the acknowledgement of country. Also, my slides should be up there now. Hoping everyone can see those. Yes, thank you for having the Poisons Information Centre this morning because, as you mentioned, we know that poisoning has a significant impact on the West Australian community. And so we're always happy to discuss, what we do, what kind of things we can look at as a community to reduce this injury and this risk. And for some, that's individual and community kind of actions and also what health professionals can do. you'll see here, even in this slide, the person is putting on an ethanol hand sanitizer, which you can imagine we've seen a dramatic increase in poisonings when COVID arrived in Western Australia, or not even arrived here when people were concerned. So we've seen a dramatic increase in ethanol ingestions in adults, children, and all ages. So that's a good example of where trends in our area of poisoning can be affected by something like a health emergency. So yes, I've been at Poisons for over 8 years. I've been a pharmacist for 20 and specialise in mental health. So this is, you'll see the links with mental health as we go through these slides. So I'll just overview the West Australian Poisons Information Centre, WAPIC, you know, who we are, what we do day to day, and how do we do it. And this kind of gives you an understanding then of what kind of exposures we see, so that then we can think about, if this is what we're seeing, how can we look at preventing some of these? I'll also give you information on how to access poisons information and what kind of data and services we work with. We'll look at a few examples of scenarios so that, again, we're highlighting how do these things happen? You know, what kind of situations do we see? Because then we can look at, well, if we want to prevent poisonings, what's our target? You know, what are we actually looking at to make sure that we see less poisonings, or we can maybe see less poisonings in the future? So strategies will be included here. And the role of other professionals, health professionals, the individuals and communities, what can they contribute? So the West Australian Poison Centre is made up of specialists in poisons information, which is what I would be classed as, so SPIES we call them. In Western Australia, we are all pharmacists. There are 4 centres, so Western Australia, New South Wales, Queensland, and a Victorian PIC, so Poisons Information Centre. And we take calls, we'll explain in the next slide, but for certain states, and in some states they're not all pharmacists, but here in Western Australia we are pharmacists, so we have it's obviously very solid understanding of medications and a lot of other chemicals, but it can be quite interesting to start training in this role, and we've just started training some new staff because some of the substances pharmacists have never come across before, so it's a really different role to your traditional pharmacist, really. We have clinical toxicologists, so obviously medical doctors who we use as consultants when required, and they consist of different levels, so consultants, fellows, registrars, and we have a medical director that does a lot of nice things that I'm not going to explain today. All right, so what do we do day to day? Now, I know that a lot of pharmacists think that we sit there relaxing, having our coffee and taking phone calls, which is true, but also a lot more specific things, because again, traditionally a pharmacist would be kind of running around a dispensary or doing those kind of roles. So it is a bit different to, you know, our traditional roles. We take around nearly 36,000 calls depending on the year. So this is the 2022 data, was 35,923 calls. And for West Australian Poison Centre, half of our calls are for Western Australia, but we also service the South Australian and Northern Territory. We do that 8 a.m. till 10 p.m. each day, and then 3 times a fortnight we work overnight. So I just very enjoyably did this shift on Sunday night, 10 p.m. to 4 a.m. in the morning, where we service the entire, you know, Australia. So each centre takes turns. So we do get not just West Australian information, but information across Australia. And those shifts can be quite different because, for example, we very rarely deal with, and I've dealt with cane toad in the eye, or, you know, not the cane toad itself, but the toxins, or we deal with funnel web spiders, for example. So it is interesting to have exposure to other unique poisonings, some types of mushrooms in South Australia that we don't have here. So yeah, this can be quite varied depending on what time of the day you're working. Who do we take calls from? So you'll see here that, you know, the large majority are classed as either family. So that's often friend, parent, you know, sorry, I shouldn't say friend, parent, sister, brother, or child, say of an older adult, or the person themselves. We call them victim. I don't love that, but the person that's, you know, been exposed to the poison. You will see there a third of the people are not related to the person, so they're either a health professional themselves. You can see 22%, and that incorporates, you know, doctors, nurses, we don't actually class carers as health professionals just because of the way it's laid out on our data collection screen. And the others could include anything from carers, people working in schools, social workers, police, ambulance personnel fit in the health professionals. So we do take quite a significant number of calls from people in the health sector or in the kind of industry. And then we have the other numbers that fit into others, friends, co-workers, or we don't know. And sometimes people do not like to disclose who they are when they're calling, what kind of relationship they have. Sorry, 2 secs, I pressed the wrong button. Here is my spelling error, human case numbers. I apologise. You will see this is taken from our annual report. So I've just snipped this and I pointed out the error. Now, this is an important slide because it shows the people that are being affected. So this is your victims, your people that have actually been exposed or potentially exposed to poisons. So you will see, you probably won't add it up quickly, but there's, when you're looking at, we know, like around 30,000, you'll see a third of the cases are for adults, and you can see the age range down the bottom there. So that age is looking at 20 to 74. So that's, a third of our calls. You will see if you actually added up the toddler and the infant, so basically people under 4, neonates there as well, small number, then that's about another third. So those really little small people can often be exposed to agents, and we spend a lot of the daytime taking those calls, for example. And anecdotally, we find when we work at night, we take less of those because those children are usually in bed. So it just depends on what time of day, how often you take which kind of calls. And you'll see, obviously, then we've got the adolescent and children taking up a large chunk as well. And, you'll see later, but we see a lot of deliberate self poisonings in some of these age groups, like adolescent as well. So this is your WHO, and I know in their learning objectives we talked about what kinds of people, are at risk. So you can see here the age groups that are at higher risk. And then we've got the actual type of exposure. So I'll describe in the next couple of slides what this might look like more, but the large majority are unintentional exposures. And this could be a bit deceiving because what you'll find is some of these calls are 30 seconds and quick because they're a child that's licked something. I had a call yesterday of a child that had licked something that was fine. So, an accidental, unintentional exposure. The intentional exposures, 17%. So we'll talk about again in a second what types of cases these might be. But they're a significant number, and they normally take probably a bit more time because there's more to those cases. When people intentionally are exposed to a poison, they tend to either be exposed to more of that poison or more numbers of poison. So you might have more agents involved. So even when I looked at that, I was slightly surprised, going, oh, it doesn't feel like that on a day-to-day, but it's probably because a lot of those unintentional ones still can be significant, but a lot of those may not end up in, for example, hospitalization or a significant outcome. We have also in there adverse reactions and other, which we'll talk about what those might look like. So this is kind of your mechanisms of poisons. So why? And that explains further from the slide before. Some of these are unintentional, some are intentional, but this is why people are calling. So poisons exposures can be quite varied. And again, if we think about accidental or unintentional exposures, they could look like the child that's accessed something, during the day or whatever. They could also be somebody who's at work and unintentionally been exposed to a chemical or had something splash in their eye. They can also be intentional exposures, so what we call deliberate self-poisonings. We call them DSPs. So that's when people either are trying to injure themselves or have a suicide attempt, or misuse. Also, of course, sometimes people are misusing a poison for its original intent. So these poisons exposures are very varied depending on the scenario. And again, there is obviously a strong link between why people are doing this and the outcome, often because when it's intentional, there's more used and often more agents involved and maybe more patient complicating factors. So we also have therapeutic errors, which basically, if you think about an error when you're trying to dose someone or you're trying to take a medicine, so they're largely medications. And they vary from being, community members like families to carers who are working in care facilities and dosing people and incorrect things happen. schools making errors, and healthcare professionals, of course. We have, hospital, GP, pharmacy settings where there's an error made by the healthcare professional, so the person on the other end ends up with an incorrect exposure to a poison. And occupational exposures are usually self-explanatory, varied depending on the occupation, quite varied. And adverse effects are unintended effects. So we cover food as well, less often because they're normally or hopefully dealt with by a more appropriate service. But we do take calls about adverse effects from food and mostly medicines as well. And interactions. Look, to be fair, in the day, these are better handled by somebody who's got individual advice for the person. So they're practicing pharmacist or doctor or whatever. But we do take calls in the day if the person's having an issue with this, or if it's after hours and there's no one to contact. And pregnancy and lactation, and similarly, there are better specialised services with access, probably better access to resources that are relevant in pregnancy and lactation in WA and elsewhere in Australia. So in 24-hour service, we do more of this in an after-hours setting. So when we're looking at this is important when we're thinking later about prevention, what are the poisons that we see people are exposed to? So pharmaceuticals are clearly up there, and one reason why employing pharmacists is, useful, because we know that they're involved in a lot of poisonings. So that's anything from, over the counter, cough and cold, to actual prescription medicines on any level. So your more restricted medicines. Again, if it's in a hospital, it could be agents that aren't traditionally seen in the community and are administered in hospital. And sometimes we see pharmaceuticals from other countries, or more often, as you can imagine, in the last 10 to 15 years, we're seeing more of pharmaceuticals ordered online. Maybe they're not even available here. Illicit substances, and they're very varied. I'm sure, that if health professionals I saw online, then, this is something that we see can spark very quickly with trends, can change. Household products, and you'll see in the next slide, they can vary from your common detergents, dishwashing liquids, to probably, things you might not think about, like, rat poisons, or, cleaners that aren't used very often. So anything around the place. And I must admit, I think the things that I was concerned about, my children were very young when I started at poisons, and the things that I was probably more worried about were less of a concern. And I probably got rid of quite a few agents in my house, saying it's probably just not worth having them around, with some of the other things that I learned as I started to take calls at poisons information. Pesticides can be, obviously in an occupational setting, but people have exposure to these for all sorts of reasons. And these can be some really significant, poor outcome calls depending on the pesticide. And we also take calls about venom. So that's, for example, an area that pharmacists and probably pesticides aren't as, practiced in before we start this job, but we take calls obviously about snake bites, spider bites, bee stings, insects, stonefish, so, sea creatures. So that's a really interesting area. And not a whole lot to talk about in prevention there. Stay away from snakes. Be careful in your shed. Don't go grabbing snakes and trying to identify them yourself. That's my advice there. I'll cover that now. And industrial chemicals, which I think, clearly are a bit more concerning, because normally there's large amounts, and chemicals that usually, if you're being exposed to them, you're not actually required, you shouldn't normally be exposed to them. And thankfully, these are fewer, I think, with good intervention from practices like yourself, Injury Matters, and organisations having really good management over health and safety. And environmental contaminants, again, much less common, which is fantastic, but that could include anything from water contaminants, soil, to more what you'd imagine is air contaminants. So you can see quite a varied list of poisons that people might be exposed to when we come into contact with them. So usually if I was presenting this in person, I say, have a guess as to what you think the top 20 are, so pretend you're doing that now, or do that to yourself. Think about what you think they might be exposed to, and I'm going to show you. So these are our top 20 agents. Yep, Panadol, well done. I can see that there. So yes, that's our number one, and always is, obviously might change. I was surprised. I thought when COVID happened, the amount of calls, we thought ethanol is going to top Panadol, but it actually hasn't. Because as we know, again, there was just so much sanitizers around with not great packaging and higher levels of chemicals. Distilleries started to make ethanol sanitizers because they couldn't, sell their alcohol in bars because bars weren't open. So it is interesting those trends that changed. But paracetamol tops the list every year, and it usually is double the second agent, whatever that is, and often the second agent is detergents. So that paracetamol is, anecdotally again, it's caused from kids actually getting the wrong dose by their parent or, someone at school. But it's also because so many overdoses, deliberate self-poisonings include an amount of Panadol, even if it's not much. So, this is obviously looking at the agent, not how it's taken and why. So you can see that will be taken across the board. And as with ethanol, very commonly someone will have alcohol on board when they have a deliberate self-poisoning. So when you saw a lot of those adult exposures and the intentional ones, a lot of those cases would include ethanol, the large majority of them. And as we know, when people have ethanol on board, they're more likely to have less inhibitions and perhaps take more there. I see the snake toolkit. So detergents are second, and that's mostly kids, to be fair. And you'll see there our next agents, and we'll talk a bit about some of the scenarios later, so I won't spend a long time on this, but ibuprofen, again, another painkiller, often taken in deliberate self-poisonings, but also given often to children, so we get those errors in provision, or they're left on the bench often because they're kind of seen as a safe medicine, so easy to access. And you'll see then making up the next top 10 is quetiapine, which you may or may not be aware traditionally is an antipsychotic, used a lot now in more conditions than just psychosis, so mood stabilization, and also, used for sleep, for conditions to do with mood often. So it's widely prescribed, and we see in a lot of deliberate self-poisonings and errors because of the large provision in our community. Bleaches, enzyme detergents, so your kind of household products. And again, unfortunately, we see bleaches in intentional overdoses as well as just your ordinary, people cleaning the floors and kids accessing the bottles or whatever. Enzyme detergents are kind of your laundry detergents mostly, to be fair, and they tend to be a bit more, of an insult to the mouth if swallowed than ordinary detergents over the counter, like your sink detergents. Foreign body, and then you'll start to see some meds. So diazepam comes in above all of the other kind of sedatives. So that's your Valium, and hydrocarbons, which include anything from petrol to, that would be if someone was sniffing a kind of, a fly spray can for the benefits of getting high, the hydrocarbon would be recorded as an agent. And I put there 11th is melatonin, which is interesting. And it's similar to what I've used at the example of the ethanol with the sanitizer. You wouldn't have seen melatonin on the list, up to 7-8 years ago. But now with the increased providing of melatonin, we're seeing it rise because it's very commonly either given in error or grabbed off the table, and it's often in some gummies, so kids might see that. And you can see how prevention is so important, because why are we suddenly seeing more? Because of things like packaging, access, and of course provision, so increased provision. And the last top 20 are full, so the last 10 in the top 20 are full of eucalyptus oil and other essential oils. Again, you'll see this increased with the popular introduction of kind of the doTERRA parties we saw, and the other kind of those companies that started doing like a Tupperware idea of, you sell essential oils. So more people had them in their homes. More people see them as natural options to clean without realizing the significant impact. So for example, with eucalyptus oil, as little as 5 milliliters, a teaspoon, can be a coma dose for a young child. So, that's a sip easy. So really important to realize that, with trends come, obviously increased poisonings because of the access at home. And I think what's interesting is these are the kind of things I thought about. People just have these sitting on their benches, because they're natural. So it is interesting to see how changes in kind of community trends affect poisoning as well. And antidepressants, there was quite a few different types of antidepressants that sat in this, clearly because people who are prescribed antidepressants are at a higher risk for being probably in the deliberate self-poisoning category. And again, we know that antidepressants are one of the most widely prescribed medicines in Australia. So what other things do we do? Because it's important that you know about our services. Obviously, we do data collection for, the government, other organisations, consultation submissions. So we did this recently for the chat around basically how the sale of nitrous oxide was going to work. So that you might know there's some changes to the sale of nitrous oxide. NANGs are becoming an increased problem across Australia. Also, we've done this for paracetamol, the rescheduling of paracetamol, codeine. So we might be involved in this research, advocacy, education, and training like today. Toxicovigilance, love saying that. Chemical disaster planning, and that would be at a higher level, looking at data, but also senior leaders being involved in what happens in these settings, and advice to industry in the occupational sector, and maintenance of local databases. So these are a few requests, for example, data situations we're involved in last year. So as I said, the nitrous oxide. I'm sure a lot of you are aware of the situation with vaping and e-cigarettes in the past few years. We've had a lot of involvement in providing data and information and advice surrounding poisonings with these. Paracetamol, as we said, scheduling. The brominoxyl is a pesticide that's also had some scheduling changes. And you may or may not be aware of the poppy seed and spinach recalls in the last basically 15 months, where we've seen people poisoned because of certain issues like contamination. So I stopped eating poppy seeds for a while because we didn't know where that was happening. But there were some specific situations with production that caused people to be really unwell. So seizures and other effects in EDs across Australia. So you quickly got to kind of be able to react to these and provide data so that we can, try and halt the situation as soon as possible. So that can be quite interesting. We have publications and information, which I'm not sure if many people are aware of, and I think would be lovely to see in more places. So like managing bites and stings and poisons in the home. That's a great leaflet that I always give to my children's school, and also obviously when I do education and training. But it'd be nice to see them. We send them out, but to see them more widely available just for prevention techniques. So what do we do? How do you get hold of us? How do you access us? Basically, yes, we are on the phone, and we do sometimes get a drink. It depends how busy it was. Yesterday, flat out, not much drinking going on about coffees, but you call us. And I have actually in my time had someone walk in, but usually it's a phone call. So that's our phone number, 131126. And the nice thing is that's the same number across Australia. So though there's 4 centres, if you call, you will go through to a poison centre no matter what time of the day, 24/7. And what we do with these calls is we gather information from the caller, much like any kind of emergency service. We have a specific kind of set of queries that we ask. We make a risk assessment using our training, skills, expertise, and the knowledge given to us. And then we provide our advice. And that can often include referral. But as I said, there may be many calls in a day that are shorter, that this is going to be fine, clean up whatever the child and do this. And this is all supposed to occur in around 5 minutes, sorry. So it's quite a quick process. Obviously, that can be varied. I was on a 12-minute phone call yesterday where there was I think 14 agents, and it was at a hospital and I had to do all this other stuff. But the aim is to be, in under 5 minutes. So it varies from some other phone services where maybe they're looking things up and getting a real researched kind of information back on maybe a medication in pregnancy. This is more of an emergency, service line where we're giving kind of acute advice on settings that are happening now, or we do get calls where people want more extensive advice and we'd refer them to someone else if it isn't actually that kind of appropriate query. So hopefully everyone has this in their phone, and if they don't, pop it in. You can always be put through to us from Health Direct or other, and we get a lot of those calls, other services. If they know there's any poisoning involved or potential, they'll put through to poisons information. So I put here, when I had these agents, we're talking about, let's think about prevention. You can only think about prevention if you think about, well, why do they happen, So looking at the kinds of things, and we're talking about this as my colleagues, why do these happen? So these are examples of what you hear before you hear. People always start with the why. Had a bad toothache, was in so much pain I couldn't think straight, and took this many Panadol. Child's been sick for days, we haven't slept, didn't know my wife had woken and given a dose. So 2 people dosing someone, haven't slept for days. The packet said take 4 hourly. So, my pet aid as a pharmacist is unclear instructions. So I took 4 hourly. There's actually 6 lots of 4 hours in a day. So that means a person might take it 6 times a day instead of actually 4 times a day as intended. And very common, I was upset and took 30 Panadol, so your deliberate self-poisonings. Detergents, I took about 3 of these calls yesterday. I went to the bathroom for 3 minutes and my child accessed this. Ethanol example, we left the sanitizer by the bed and this patient with dementia has drank the sanitizer. Or we didn't know the sanitizer was in the room with the person who maybe is acutely suicidal, and they know that they can access that ethanol in a dangerous level. We're at Nana's house and her handbag was on the chair. Very common, we've grabbed a handbag out the back of the car. People keep loose medicines in there. And I've just done a list of kind of examples for this lot, thinking about medicines. Very commonly these calls from hospital start with patient had a argument with partner or with their parents or with their friend, and then they took blah, blah, blah. So a numerous number of medicines. Carers, we didn't notice that the lunchtime was given late today because the person was out. So not good recording or not good, matching of recording and dosing of medicine. So the next people give the dose at the normal time and it's only an hour apart. Nurses, we didn't notice that the evening meds are missing. It seems like something's wrong. So they're using Webster pack in a setting and it doesn't make sense. We get people that call up and say, what would happen if someone took 15 of these tablets? And when you start talking, obviously someone has taken these. So again, a deliberate self-poisoning situation, or not looking for a second, or, the kids are in the back playing with an object and now it's gone, they've swallowed it. Very common, as we said, the doctor will call with if someone's had a family crisis, they've had a bottle of wine, this many diazepam, and this antidepressant, and this, and this, and this. And then we get situations, for example, of misuse. So not uncommon to have a group home call where they've got a bunch of young people and this person's been found sniffing, this was a case I took that years ago, sniffing insect spray under blankets to get the high from the hydrocarbon. Things like they just love the taste. Gummies, melatonin gummies taste great. Not ideal. Ideal to get to take them, not ideal in poisoning. Or I just wanted to sleep, but they're also crying, suggesting there's some mood issues. And when you get chatting, there's an attempt to actually injure oneself when they've had this many medicines. And there's lots of different situations where we see these other agents taken. I thought I'd give them this tube to hold or my medicine to hold while I was changing their nappy, and I've changed a lot of nappies. Yes, it's so nice to do something to distract them. So I understand how this happens. Or I forgot on my tablets. So, of course, I'll take them all today. I haven't taken them for 3 days. So I'll take them all at once because that's what they think is the right thing to do. Or again, those deliberate self-poisoning. Had drinks, suddenly they're taking all their medicines that they've got around. So this is really important because if you start looking at this, you can look at how do we stop this happening? How do we reduce the number of people in this situation that they're exposed to these poisons? So we'll look at, these kind of situations, how might we reduce poisonings, and I've used that to kind of lay out how we might address prevention. So prevention is the best cure, correct? Can we reduce these numbers by looking at why and how people access poisons, why they might do it? And that's really where different professions come in, talking about collaborating to reduce poisonings in Western Australia and obviously across Australia. So talking about poisons exposures. So that's your accidental or intentional exposure to anything, as we said, from paracetamol to detergents to chemicals. As I said, I'm not going to include snake bites here because my advice is stay away from snakes. Don't play with them. Had a funny call the other week about someone playing with some snakes that did not end well. So I advise you not to do that. But other than that, poisons, what do we think about? So medications and potential poisons, thinking about individuals in the community, so homes, workplaces. We get a lot of calls from care facilities. So when I talk about care facilities, I'm talking about nursing homes, sometimes staffed by health professionals. They're often a bit easier. Others that have carers, that are working around the clock, or it might be a group home, young teenagers. And we've got to think about the basics that we kind of talk, that are in those leaflets, keeping medicines out of reach, high and locked, or in an inaccessible place. Supervised provision of medicines, thinking about ages that are appropriate, education of ages that are appropriate to access medicines themselves. How do we know how many they took? Even, all jokes aside, being a pharmacist, the last thing I want to do is call poisons information when I work for them. So when I am tired and my children are sick, I get my husband to check the dose of Panadol I'm giving my kids, because I know that I'm not actually acting as a pharmacist then. I'm acting as a mum who's tired, dosing my sick child that's been up for 3 nights. So even supervised on a formal level at a care facility, but at home, having someone else just have a quick look. Looking at medications in sealed containers, so storage of medications is key, because as I've given examples, that handbag access is more common than you think, or keeping them in the car console where a child can access, or often adults taking the wrong medicine because they're just kept on the bench and they picked up a strip because that's where they left it, but the partner swapped over and that's a different strip of medicine. It's about recording doses. So in health settings, recording is really important. In care homes, even more important, because we have non-trained professionals dosing medicine. So everything needs to be really clear for the reduction in errors or mistakes or confusion with dosing people. And I also mean at home, again, I'll always recommend on the phone when we're dosing the medicines to have really clear layout of what everyone's been given, so that it's easy to see. And storage and disposal on any level, so at home, but also, industry and education on that, and, workplaces, where do we keep these chemicals? Are they going to fall and go into someone's eye? And of course, though this isn't what we're talking about today, we can't ignore that we need to look at, on a larger level, reducing deliberate self-poisonings. My other area, as I said, speciality is mental health, and we know that suicide is a leading cause of death for 15 to 44-year-olds. So we know that it's deliberate self-poisoning. Poisonings are the second most common way of suiciding, dying by suicide. So we know that reducing deliberate self-poisoning is important here. And that is obviously a huge area, mental health policy and intervention, having services available so people can maybe get the help before they take the overdose. We get a few calls of those. What happens if I take this? I haven't taken it. And we simply refer on, because though I might have experience in that area, that's not our area of expertise. And then looking at access. So those vulnerable people, how do we make it harder for them to access these medicines, but in a way that's appropriate, so we're not just policing. And also there's other groups like people with dementia. That's a common call. They access medicines because they're unsure if they've taken their dose, or they drink a bottle of ethanol sanitizer because they don't know not to. So things like locked boxes, Webster packs, daily pickup services, which, doctors, GPs can instigate. So there's lots of things we can do day to day to look at reducing access for people that we know are more likely to be exposed to poisons. The therapeutic errors where we're giving someone accidentally the wrong dose, as we said, double check every time, recording carefully, calling someone before we do it. The amount of calls we take of, oh, can I take this with this? Or can I have 20 mils of this? And we're like, have you done it? They're like, yeah, I did it already. Then I thought to call. So, advising people, if they're really educating well, if they're not sure, check first. In facilities, having 2 members check, as I said, of the staff, really important. And a really common theme we'd love to get across here: if it feels wrong, don't do it. I've taken numerous calls of people giving 3 syringes full of paracetamol to a child because they've read the dose wrong. And we think, if there's more than 1 syringe, just go, hold on, let's double check this. So again, in a facility, in a hospital, if it feels wrong, if you're like, this seems like too many vials, just stop, have someone else check. Leaving medications in their original containers in workplaces, hospitals, pharmacies. We see some terrible things sometimes, is really important, and obviously in the home. And returning unwanted medicines and disposing of things appropriately, so chemicals, and that's normally, we refer that on to the government itself, so the appropriate department, be it a pesticide or whatever. And using things like Webster packs so that we can really easily monitor errors. And with industry, this is obviously much, larger area, looking at the actual labelling and scheduling of products. And you will see with some shortages, we've gone, and there's been a bit of uproar about it, from having kind of, a certain number of medicines available in a blue bottle to a load of medicines available in the same blue bottle, because that's all they could access for the time being. And that can make a really big difference when people take 7 medicines in a row, the colour of the tablets or the bottles. So, simple things like that can make a large difference to errors in taking tablets, accidental or intentional as well. So is it easy to just pour down the throat? Do we have to pop them all out? And in that time, we have a change of heart, which is very common with deliberate self-poisonings. Health facilities, looking at appropriate staffing, so there is other people to check. People aren't overworked and unable to think straight when they're administering medicines. Having good policies to ensure that errors are less, and training, obviously, of the staff. And then thinking about the actual time of the prescribing and provision of meds. So do doctors, pharmacists, and we know this, do we have enough time? Are we being paid appropriately for the services? So we do have enough time, to actually give the best provision of medicines. And that is looking at staffing, counselling, labelling, directions. Are they all appropriate? And education of staff in all these areas we're talking about, including the wider community like schools, workplaces, and really looking clearly in, especially the government about what kind of requirements we have, because we know when we increase policy and, those kind of official requirements that the workplaces will follow through to, tick the boxes. So that's quite important. Occupational exposures, I think the key message is to have those policies and procedures that hopefully are in place from, the government organisations, and follow them really clearly. To really quickly seek advice, the amount of time people call us 5 hours after they're home and no one's called us in the day from the workplace, and it's especially a pesticide or something, time wasted. And to make sure that we have readily available information on products so that when these workplaces have an agent, it's not, oh, we don't know what it is. We don't know how to find information on that. So making sure documents are kept up to place, ensuring there is people trained and educated on site about the chemicals or the agents and how we use them, and storing them appropriately. And really, as I said, that's important that industry backs that up with having, very important mandatory standards and policies for workplaces. In terms of adverse effects, quite, literal answers here. So read the information before you take them and appropriately, really quickly report and record adverse effects. And that includes, health professionals doing this, and promptly seeking advice rather than, again, waiting 2 days before you get help for that shortness of breath. And that's probably, I think this is more appropriately managed from an industry point of view, in that we need to make sure we give really good advice on adverse effects before provision of meds. And I work for Curtin University training new pharmacists coming through. It's something I drill in about, not just handing over a leaflet, actually letting people know about realistic adverse effects so they know what to look for and how to seek help if they happen. And obviously health professionals educating the community more. So there's more information out there on, if this happens, this is how you get help. There is a 24-hour line you can call if it's after hours, poisons information, or you can do this. And this last point, I didn't know how to word it, means making sure policy is appropriate. So we get a lot of calls from care groups saying we've had someone that's missed a medicine, or this effect, and it's really not relevant to us, and would be better answered by a professional looking after the person. So say a pharmacist or GP working with the patient. So making sure we're using the best resources for the best outcome for the person in front of us. When looking at interactions, quite similar, I think, to adverse effects, because they're similar to, they fall into the same category of kind of medicines, not doing exactly what we'd hope they do, or interacting with another, is again seeking advice before we take the medicines. It seems very obvious, but it's so often that people will, take and then ask. So trying to educate the community on this is really important. Always check before. It's okay to ask 4 different people. Making sure that health professionals don't make people uncomfortable for asking questions. And again, using the health professionals involved in the care so that they have appropriate access to all of their records. On our phone calls, we don't have access to any records, and it can be quite difficult, for example, for a care worker to try and read 20 medicines and conditions, and often they aren't sure and they get it wrong, and we want to reduce the number of errors. So in industry, similar to the last slide, it's about the provision of meds being done as best as possible, particularly by pharmacists providing them. Health professional education, so trying to actually inform people, this is what we do if we have interactions, this is how we reduce this. And again, using the appropriate people involved in the person's individual care can be the best way to manage this and prevent the poisonings. And pregnancy and lactation is quite a specialised area, to be fair. Again, same thing. It's the amount of people that will take a medicine and then go, oh, I'm pregnant. Now, that's easy to say now. When you have pain, you just take the medicine. But again, making sure that the pregnancy care is really fully laden with, always check before we do this, really constantly reinforcing the need to don't be embarrassed about accessing advice. The amount of people that are embarrassed to call and ask questions overwhelms me. So making sure people are really comfortable with that, and promptly seeking advice from really specialist services. So we would refer a lot of pregnancy cases on if it was in office hours, for the reason that there's some very specific specialist considerations in this area. And you'll see the same things here in industry, actual provision of meds and prescribing being appropriate, us educating the community better, so people aren't resistant to coming to ask questions and asking early, and using people in the patient's individualized kind of care plan. And hopefully it's been clear over their whole talk how much everyone can really help with poisons prevention. So, obviously individuals, friends, people, around us that help with medicines, that help with, pesticide exposure if they're spraying things in their yard. There's things we can all do about storage, consideration of others, informing others about what we're doing, documentation. That's pretty obvious. But workplaces, it's making sure people are trained. We have first aiders, that supervisors and colleagues understand their involvement and their commitment and what's the word I'm looking for? Responsibilities for storage and management of potential poisons. And in terms of other professionals and stakeholders, I've just listed examples here of where this could, really help with prevention, and we could work together. So care workers, in aged care and group homes have a big role to play in the provision of medicines particularly, but other poisons, like we say, the use of sanitizers and cleaning products, and good education and training and understanding of how they could reduce poisonings in this setting. Social workers, obviously, depending on the setting, used in so many areas effectively. Education, the provision of mental health services, again, not being able to ignore the amount of deliberate self-poisonings we have and deliberate ingestions. And obviously interventions in the home are also helpful with social workers, so how people are managing their home life to make sure that it's as safe as possible to reduce access to certain agents. Psychologists, education and mental health services, and you'll see that's repeated a few times there. Pharmacists obviously have a very large role to play in provision, advice, reminding people about Webster packs and dosette boxes and how we can reduce access to medicines. Nurses, education and their individual advice, and the trust placed in nurses, normally first on the trust list every year. How can we use that to our advantage with the community? Doctors, similarly, the education they can provide with the provision of meds, the suggestion of Webster packs, the doctor suggests that it's taken even more, as gold than the pharmacist suggesting it. Individual dosing, picking up every day from the pharmacy for people that are maybe vulnerable at the time. And then, of course, industry. So making sure that policy exists to reduce, access to certain types of medicines. That's why medicines have schedules, so that certain people can access, or it has to be available by a certain type of prescription. Policy that looks at, like we say, chemicals and how they're handled and stored at work. Documentation, ensuring that we make sure these are really strict rules. And also, obviously, the pharmaceutical industry, packaging, labeling, access is really important. And that can be similarly reflected in government involvement. So making sure that industries are well staffed. These, I won't get into it, but these arguments about how, we're keeping industries alive and fulfilled, that makes a difference to how people provide their care and their education and the time to do those things. Mental health services, obviously an enormous issue, and monitoring industry and making sure that that's really appropriately done to reduce poisonings. And of course, you've got groups like, so Injury Matters, where we've got groups that are really aiming to reduce injury at a larger level, including poisonings. And these are all key to, reducing the access, injury and unintentional exposure, as well as deliberate self-poisonings with poisons as we see every day in our calls. So thank you for listening. I think I've just managed to stick to the time, so that went well, and I'm happy to answer any questions.
Thank you, Louise. That was really interesting. I really enjoyed that last slide, to be honest, just to kind of highlight that everyone has a role to play and everyone is playing a role of some kind, even if it's just immediate family. I am going to wait for questions to come in, so please pop your questions in the chat box and I'll facilitate them. But I had a question around, I guess,
Yep.
like, I just wanted to know what, did you see any personal trends, throughout COVID, around alcohol poisoning? And I'm not talking about ethanol and the sanitizer, but like
Actual
consuming,
alcohol.
yeah.
Well, the tricky thing is when you're doing that kind of, it's just a matter of our database, is that it's not like they are classed as beverages, but this is the tricky thing is I could tell you anecdotally what I saw. Do you know what I mean? Because that data is harder to get because it depends how it's classed. So it's classed as an ethanol. But myself, it was interesting. We saw things like certain substances, other substances start to be used more, like medications. So there were some things that are traditionally antiepileptics that are used in pain, and they seem to be using more because there went a bit of a rumor around that they were giving a similar effect to, say, meth, and you couldn't get meth in Perth at the time. Alcohol particularly didn't notice an increase in use, but you got to remember, we don't see people just using it casually. Do you know? And that does, so our data isn't always saying the trends. And I have had people ask, questions before about that. We don't see people that is having a drink and sitting at home and maybe having a bit too much. We often see it more in, an overdose setting. So where they've used alcohol, or we do obviously get calls from people that have had too much, and it's often not them, it's the parent or someone else. So particularly no, but that doesn't mean that it wasn't happening, if you know what I mean. The actual everyday use. And that's what's tricky about our data, is it tells you a certain set of information. And we were discussing this the other day. We don't get a lot of calls about, say, for example, heroin, because usually the ambulance doesn't need to call us about that. It's a very straightforward management. Do you know? So it doesn't mean there's not a lot around. It means poisons information doesn't get a lot of calls because they know exactly how to manage that easily, and it tends to go straight to hospital. So unless it's going to a hospital that doesn't know how to manage this, which doesn't happen, then we won't hear about it.
Yeah, okay.
I saw a
Thank you.
question there, yeah.
Yeah, there's been a few. So one that Rosemary has asked is, what has been the increase of vaping or nicotine poisons in the last 3 years?
So look, I don't have it on me, but what we know is we've done a lot of data research. So we definitely have seen, obviously, dramatic increase in vaping, and we've got a lot of education articles that we get sent from other countries, often talking about the damage we're seeing from vaping, which is concerning. And the biggest problem we see ourselves is that the confusion between nicotine and nicotine-free. So we see a lot of people that think they're using nicotine-free, and they're not. And so we see nicotine poisoning, which actually you don't see that often before vaping or e-cigarettes, because people just didn't have enough cigarettes to get nicotine poisoning. But we're seeing young people or adults, as opposed to just children, having nicotine poisoning from vaping. We wouldn't see, say, for example, in our role, a chronic problem, because they would tend to see specialists regarding that when they went for their appointment. So we would get a call about the person acutely overdosed, and a lot of that is kids grabbing their parents' vaping solution and drinking it, which is then nicotine ingestion. So though we do see it in adults and younger people, because it didn't exist before, people didn't eat cigarettes, now they're actually ingesting it or inhaling it. Yeah.
Okay. Another question is, with new CBD THC preps, has there been any significant reports of OD or poisoning?
Interestingly enough, I, again, anecdotally think we saw more problems right before, because people were ordering it online at a very increased rate, and genuine people ordering it because they knew that it would be good for them. And the problem is, when you're buying non-standardized products, you see all sorts of reactions. And I took some terrible calls of young people whose parents had purchased it to treat them for significant conditions. So now, with the introduction of, actual standardized products, as we say, that have less THC, then that's often less of an issue. But I definitely have taken more calls, as we said, like kind of the melatonin and the ethanol. When they're more available, you will see people that, oh, I'm drowsy, or I've had this and this and this together, and I'm suddenly feeling this. But because they actually are better prescribed currently, we're still not at the peak of prescribing, I think they're being used more appropriately. So I think we'll probably see an increase in that. But when we see agents that are bought online and, claim to have lower levels of THC but don't, we've definitely taken many of those calls.
Yeah. And I'll end with the last question from Helen around, she was wondering if you were able to briefly outline the process when a call comes through, especially when it comes to DSP.
So deliberate self-poisonings, look, it varies dramatically, but basically, our risk assessment involves, who's the person, where are they, basically, as in rural with someone else, and what is their state. So that often can be offered in a sentence or two. They will just literally call and say, I'm with my friend and this has happened and they're doing this right now, they're vomiting or whatever. Or someone calling saying, what happens if I've had 20, or someone's had 20 tablets, and you have to get all that information out of them. Are you drowsy? Are you listening? Are they slurred speech? So we take off whatever information with that deliberate soil poisoning, we try and get as much as possible, because all I'm trying to think is how much time have we got for this person to get medical help? Is something significant going to happen in between? For example, if a seizure is imminent, then I want them to go by ambulance. You know, if it's not, then their parent can take them, and then I'm like, where are they? How long is that going to happen? And also that there's very rarely something you can do, and I'm just being very broad there, to prevent or to stop it happening, you know, getting worse. But is there something they can do, like, you know, take all the medicines with you so we can see inaccurate information? So how can we make the next step as easy as possible? And in some cases yesterday, it was like, can you please make sure that they call me at the next step because there's this and this to discuss.
Yeah. Cool. Thank you so much, Louise.
Thank
That
you for
was
having me.
no worries. I'll just quickly wrap up with just highlighting or the resources we have and just next steps, I guess. So Injury Matters have a couple of resources on our website, one on alcohol and medication interactions, which is kind of something that we talked about and was mentioned today. Also, and this was on your slides as well, Louise, but the poisons in the home, there's a resource on the St. Sir Charles Gardner Hospital website, as well as a poisons information data, which we definitely need to update, but that is there as well for some, yeah, reference for you guys. And come on, next slide. And then next steps, I want you all to be, I would love for everyone to be part of the Injury Prevention Network. It's a network where health professionals uh, come together 4 times a year to talk about injury prevention work that is being done in WA. And it's a great one to be part of, to share learnings and I guess collaborate. It's a great way to network and collaborate with the sector as well. So if you're interested in being involved in that, send me an email and I'll add you onto the list. We also have Connected, which is an online networking platform for health professionals that work in the injury prevention space. You get matched with another health professional every 2 months, and it's a great way to connect with other people in the sector as well. And then evaluations, we want to know what you thought about today's webinar, and there is a survey link that will be popping up in the chat shortly, and I'll send that through to you guys in a follow-up email as well. But we'd love to hear what you thought about today and if there's any suggestions for upcoming trainings for Injury Matters as well. And that was kind of it. Thank you so much, everyone, for joining in, and thank you, Louise, for a great presentation.
Thank you. Have a good day.
Bye.